in this video MCQs that have already been asked in previous years for NEET PG entrance examination on the topic of maternal adaptations in pregnancy. In this video, I will be covering the MCQs that were already asked, and in the next video, I will be sharing you with the important one-liners and some clinical assessment questions. So the first question is, periconceptional use of the following agent leads to reduced incidence of neural tube defects. We all know this answer is folic acid, and the prophylactic use is around 0.4 milligram, and therapeutic use is 4 milligram, and we give a single tablet of 5 milligram daily to the patient. Now the second question, Hagar's sign of pregnancy is uterine contraction? No, uterine contraction we all know they are called Braxton Hicks contraction. And bluish discoloration of vagina? No, this is the Jacquemus sign of in pregnancy. We have discussed in the lecture of maternal adaptations in pregnancy. And softening of isthmus? Yes, because of the softening of isthmus in Hagar's sign, we can approximate our internal and external fingers through this softened isthmus. And quickening, it is also not Hagar's sign. Now some hormone responsible for decidual reaction and area stellar reaction in ectopic pregnancy. It is progesterone, and progesterone is the hormone which is present from the luteal phase of pregnancy, luteal phase of menstrual cycle, and it prepares the body, it prepares the uterus for conception. The uterine blood flow at term. The uterine blood flow at term is, we have discussed in our lecture, it is around 750 ml per minute. So the answer is D. In a non-gravid uterus, the uterine blood flow is around 100 ml per minute. Use of folic acid to prevent congenital malformation should be best initiated. It should be best initiated, yes, before conception, and that is also around 3 months before conception. Folic acid supplementation reduces the risk of, yes, it is neural tube defect. This is a folic acid supplementation is very important because this is repeatedly asked, and it is reduces the risk of neural tube defect. So this is a very important question. Estrogen and progesterone is in first 2 months of pregnancy are produced by, they are produced by corpus luteum up till 8 to 10 weeks of gestation. Thereafter the work is taken over by placenta, and the corpus luteum atrophies, and at term it becomes white in color. In early pregnancy, corpus luteum looks orangish, and after the work is taken over by placenta, it is converted to yellowish and later whitish because of calcification. All of the following statements are true except oxytocin sensitivity is increased during pregnancy, during delivery. Yes, of course, it is increased to facilitate the delivery. Prostaglandins may be given for inducing abortion during third trimester. Maybe this is some little wrong option. There are no abortions in third trimester. You can say inducing labor in third trimester. Yes, prostaglandins are used. In lactating women, genital stimulation enhances oxytocin release. Yes, this is also true. Not only genital stimulation but also the breast stimulation increases the oxytocin release. And oxytocin is used for inducing abortion in first trimester. No, because the receptors are low, and also the sensitivity of the receptors are very low. So oxytocin is of no use in inducing abortion in first trimester. In normal pregnancy, character of vagina, increased pH. No, the pH becomes more acidic because of the increased lactobacilli and increased conversion of glycogen to lactic acid. So the answer is B. During fetal life, maximum growth is caused by insulin and insulin-like growth factors. Most common cause of platelet decrease in pregnancy, we have discussed in our video covering the topic. It is benign gestational. It is normally seen in pregnancy in many women, and the lower limit is reduced to 1 lakh per cubic millimeter, and it does not cause any harm to the woman. So the answer is E, benign gestational. All of the following may be observed in a normal pregnancy except. All of the following are observed. Okay, so what is not observed? So let's see one by one. Fall in serum iron concentration, yes, it is seen. Increase in serum iron binding capacity when it requires iron. It's an iron deficient state pregnancy, so serum iron binding capacity is increased, yes. Increase in blood viscosity, no. The plasma osmolality decreases in pregnancy, so increase in blood viscosity is not seen. And the last option, increase in blood oxygen carrying capacity, yes, it is increased, although there is relative anemia, but the oxygen binding is increased. And the on arterial gas analysis, the PO2 rises up to 105. So D is also correct. So answer is C. Weight gain in pregnancy is related to all except ethnicity, yes, it has an effect on weight gain. Smoking does not have effect on maternal weight gain, but it has got a role in causing fetal growth restriction. Socioeconomic status, yes, it has a role. And preconceptional weight, yes, it also. So answer is B, smoking. All of the following changes are seen in pregnancy except increased stroke volume, yes, it occurs. We have already discussed in detail in the lecture. Increased cardiac output, yes, it is also seen. Increased intravascular volume, yes, this is also seen. But increased peripheral vascular resistance is not seen. There is fall in peripheral vascular resistance as well as fall in pulmonary vascular resistance. So answer is D. What are maternal physiological changes in pregnancy? Increased cardiac output, yes, this occurs. Increased tidal volume, yes, this also occurs. The respiratory rate is not increased, but the tidal volume is increased. Increased vital capacity, no. Decreased fibrinogen, no. Fibrinogen levels, they rise by around 50% during pregnancy. Decreased plasma protein concentration, although the total amount of protein in body is in blood is increased from around 180 gram to 230 gram, but the value is because of hemodilution, because of increased plasma volume in retention of water, the levels when you check on biochemical analysis, they are lower. So in decreased plasma protein concentration decreases, but overall protein increases. So answer A, B and E. Which cardiovascular change is physiological in last trimester of pregnancy? Mid-diastolic murmur. No diastolic murmur is physiological. Only systolic murmurs can be physiological. So it is not A. Occasional atrial fibrillation. No. Any arrhythmia, not physiological. Shift of apical impulse laterally and upward in left fourth intercostal space. They have asked in last trimester. So because of the growing fetus and shifting up of the diaphragm, it occurs. C is the answer. Cardiomegaly, no, it is also not seen in pregnancy. Friends, if you have any queries, do ask me in the comment box. I will be happy to answer. And if you like,